Although testosterone products were approved for the relatively narrow indication of severe testosterone deficiency and hypogonadism, of the hypothalamus, these indications are actually used. Over 80% of testosterone prescriptions in the US are for middle-aged and older men who have mild age-related declines in testosterone levels or overt cardiovascular disease in this patient population to potential cardiovascular risk. And yet data therapy in this setting was sparse. Signals of cardiovascular risk, they were inadequately sized at high risk or systematically define or collect studies, but they provided mixed results and again were limited. Cautioning about the uncertainty regarding cardiovascular safety. And then in March of 2015, they issued a guidance requiring testosterone manufacturers to clearly address the question of whether testosterone stroke. There are several distinctive features of the TRAVERSE trial. It's by far the largest of any testosterone trial in terms of the number of participants. And the average duration of treatment with testosterone was nearly 2 years, a relatively long period compared with other testosterone studies. We specifically enrolled men who were at high risk for cardiovascular disease, either because they had multiple risk factors or they had known vascular disease. These were the most vulnerable patients who would be most likely to show an increased incidence of cardiovascular complications if testosterone did in fact increase risk. We applied a rigorous definition of hypogonadism for men to be included in the trial, requiring symptoms and 2 measured testosterone concentrations below the normal level, which was 300 nanograms per deciliter or 10.4 nanomoles per liter. We carefully monitored the dosing of testosterone to prevent blood levels from becoming too high. We followed the patients closely and specifically collected and defined all cardiovascular endpoints. And we used an independent committee to provide an unbiased assessment of which suspected cardiovascular events actually occurred, adjudication. Our endpoints focused on unequivocal and important outcomes, including cardiovascular death, myocardial infarction, and stroke. And we used statistical adjustments to account for the influence of patients who prematurely stopped the drug to be sure that we were able to detect if there were any safety signals for cardiovascular risk. The trial enrolled 5,204 patients, of whom 53% had pre-existing cardiac disease and 47% had multiple cardiovascular risk factors. The mean testosterone level at baseline was 227 nanograms per deciliter, or 7.8 nanomoles per liter. Reminder that 300 nanograms per deciliter, or 10.4 nanomole per liter, was considered the lower limit of normal. Over 2/3 had diabetes, over 90% had hypertension or hyperlipidemia, and nearly 2/3 had elevated CRP marker of inflammation. The average duration of treatment was 22 months, and patients were followed for an average of 33 months. The cardiovascular safety endpoint of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke occurred in 7% of patients randomized to testosterone versus 7.3% of patients randomized to placebo, thus meeting the FDA-mandated criteria of non-inferiority and establishing that testosterone replacement therapy did not increase the risk of major cardiovascular complications. Sensitivity analyses adjusting for patients who prematurely stopped the testosterone showed very similar outcomes. There was no increase in cardiovascular risk with testosterone. By adverse event reporting, there were small increases in rates of pulmonary embolism, atrial fibrillation, and acute kidney injury, which may have been real or may have been due to the play of chance. These findings of cardiovascular safety in TRAVERSE help clarify the previously conflicting and inconclusive data from prior trials and the observational analyses. It's important to emphasize that these results apply only to men with hypogonadal symptoms and low testosterone levels. and should not be used to justify treatment of broader populations of men not studied in the trial. In particular, we have no evidence for or against cardiovascular safety in settings where testosterone is used in men who have not been documented to have low testosterone levels, or in those without symptoms and without adequate monitoring of the dosing and the testosterone levels, or in doses that were intentionally designed to produce excessive blood levels. Previous trials have shown that testosterone treatment in older men with hypogonadal symptoms does improve sexual function, increases bone mineral density, corrects unexplained anemia of elderly, and moderately reduces depressive symptoms. However, because testosterone deficiency is not a life-threatening condition, uncertainty about the cardiovascular outcomes weighed importantly upon the treatment decisions made by clinicians and their patients. So our findings of testosterone's cardiovascular safety will hopefully facilitate a more informed consideration of the potential benefits and risks of testosterone treatment for middle-aged and older men with hypogonadism.